Hello, friends. It's such a privilege to be a part of the Kerala Ophthalmic Society in this virtual conference. I really thank and I'm grateful for this opportunity. Thank you, Dr. Chandrasekhar, for inviting me to be a part of your IC. Um, so, I'm going to talk to you about this very important chapter of NABH, patient rights and education. And it's pretty much impossible to cover this chapter in 10 minutes, but I will definitely try my best. So the first standard says the organization protects patient and family rights during care and informs them about their responsibilities during care. Friends, you have to remember that the NABH assessor will come to your doorstep only maybe once in a year or once in 2 years, but your patient comes to your doorstep every single day. And if they can be your brand ambassadors, they are definitely going to bring in a lot of goodwill to your center. So the PRE 1A, patient and family rights and responsibilities are documented and displayed. Documentation, wherever there is a documentation needs, there is an asterisk, and you need to have a proper documentation of what are the family rights and patient rights you're talking about. We will talk about them in detail through the chapter, but they should be included in your manual, of course, and they should be displayed in all strategic areas like your lobby, registration, billing, basically all patient care areas. PRE 1B, patient and families are informed of their rights and responsibilities in a format and language they can understand. So obviously they have to be bilingual. One is English and another is your vernacular language. So these are the examples of rights and responsibilities of patient displayed in bilingual at our center in Bangalore. And PRE 1C, staff is aware of the responsibilities in protecting patient and family rights. So obviously, if you really mean to see that these responsibilities and rights of patients are taken care of, then your staff should be sensitized and trained, and there should be training records available. PRE 1D says violation of patient and family right is recorded, reviewed, and corrective and preventive measures taken. So this is very, very important. Compromising the privacy and confidentiality of the patient, disrespect to any religious and cultural needs or soliciting monies, etc., are completely no-no. So for your organization, you should have an entire list of things which cannot be done, which falls under the category of violation of patient rights. So, and there should be, of course, an SOP for mechanism of registering complaints for RCA and CAPA, patient grievance redressal register, feedback form, suggestion drop boxes, grievance committee should be taking up these complaints very seriously, and there should be a time limit. You decide that within how much time you will be able to do the redressal. Say for example, in our organization we say 72 hours. So within 72 hours, within that time frame, there should be a solution given to the patient, and a preventive action can be taken at a later date after the CQI committee has discussed about this. The PRE2 says patient rights support individual beliefs, values, and involve the patient and family in decision-making processes. So PRE2A says, talks about personal dignity and privacy during examination, procedures, and treatment. For example, female doctor nurse, single patient examination at a time, CCTV not present in consulting procedure and OT room. Avoid discussing patient in public spaces. Typically, what the elevator talk should be avoided. And of course, an explicit informed consent is taken before photography and videography. That is very, very important now in this world of digital media, and everybody wants to project. Whenever you're putting up photographs and videographs of your patient, see that the consent is taken. It should not be done without their consent. Patient right includes protection from abuse or neglect. So interpretation is that list of patients neglect and abuse situations should be written very clearly in your organization. Special attention to vulnerable patients, patients who cannot speak out, elderly, neonates, infants, physically and mentally challenged patients, patients under anesthesia. Common examples are wheelchair straps, bed railings, grab bars, wet floor signages. Anti-sexual harassment committee should be in place for not just for your staff, but of course for your patients also. And there should be a proper grievance mechanism, grievance redressal mechanism. PRE2 says patient rights include treating patients' information confidential. Now, statutory requirements with respect to privileged communication shall be followed at all times. For example, not disclosing an HIV status of the patient is also a part of your responsibility. Patient right include refusal of treatment, of course, list of consents informed consents, list of all informed consents which are required should be displayed, and it need not be displayed, but your staff should be aware. And like general consent for OPD is something which is been, you can negate that now with the 5th edition standards. They said general consent is an implied consent. So that needs not be taken. One piece of document is reduced. So that's good news for us. Consent for, of course, all surgeries, all procedures, all lasers, and for any video, photo for in-house marketing. Patient right include right to complain and information how to voice complaint. We already discussed that. Patient right include information on expected costs. So then approved tariff list should be present. Financial counseling should be done, and a statement of understanding and acceptance is what we take a patient signature on that we have understood that this is a cost and we are agreeable to that. And that really goes a long way in patient satisfaction. So your billing policy, of course, should be uniform, uniform pricing for the same bed category, and it should be transparent. Now, displaying OPD charges is something which your Clinical Establishment Act might also ask for. So if they do ask you, please do that. Patient has a right to have an access to clinical records. So you definitely, with the due permission, of course, see, they have a right, but then again, you want to maintain confidentiality. So they will have to come with a request, an email or a written request by the patient or authorized relative or authorized person by the patient who can access the clinical records, and you are supposed to give the copies of the clinical records after that. So a documented policy for obtaining patient or a family's consent exists for informed decision making about their care. So about the consent, like what I already said, general consent is not needed now. And the list of situations where informed consent is there should be very, very, we already spoke about that, that all procedures, everything, even a callation or a foreign body removal, there should be a consent taken for that. And that is mandatory. That is very, very important, because if there is a complication and if a consent is not taken, then there is a problem with that, and you can be taken to the court of law. So informed consent process adheres to statutory norms. This includes, but is not limited to, taking consent before the procedure and at least one witness signing the consent form. Informed consent includes information regarding the procedure or implant, its risk, benefits, alternatives as to who will perform the requisite procedure, and our implants in a language that they can understand. So these are in a consent. Now, how do you, we always ask what should be there in the consent, the consent, these are the exact things what should be there in a consent: the name of the doctor, the procedure, the implant, its risk, benefits, alternatives, and who will perform. Suppose if a doctor under training is performing, that also should be very clearly mentioned, and the language in which the patient understands. That is very, very important. And the procedure describes who can give consent and when the patient is incapable of independent decision making. So you should be written in your SOP that who is going to, what is your, who will give the consent. It should be a sibling, kin, legal guardian, or a spouse, in case if the patient is mentally or physically incapable of giving a consent. PRE 4 says patient and families have a right to information and education about their healthcare needs. So they are educated about informed decision pertaining to a plan of preventive aspect, possible complications, expected result, and cost at the time of admission. So patient counseling for all these things is very, very important. Now, for example, the use of safe and effective use of medication and potential side effect of medication. For example, a lifelong use of glaucoma medication is required, has to be sort of taught, and awareness to be created in form of brochures, leaflets, or whichever way you would like to do that, displays, visual displays. And for example, side effects of steroid drops. So it's important that patient understand that a steroid drop cannot be continued lifelong. Patient families are educated about the specific disease process, complications, and prevention strategies. So this should be done in whichever way you want to, but it's very, very important. And they're educated about the preventive healthcare associated infections, HAI, and in COVID times has really brought us to this realization that this particular standard is so very important. There's an increased focus on hospital infection control, on hygiene. I think the post-COVID world will be a much more hygienic hospital environment, a much more kinder hospital environment with so much of psychological trauma going all around. And standard precautions, universal precautions, safety from transmission is going to be a norm, not just for NABH hospitals, but for all hospitals. And so, yeah, brochures and posters, educational models, audiovisual displays, in a language, again, language, something if you put it in English and it's not there in the vernacular language, it's not going to be agreeable to the NABH assessors. The PRE5 says, of course, right to information on expected cost. There should be a billing policy and the charges should be transparent. The packages should be available with the counselor, and just to ensure that there is no hanky-panky business going on over here. The ethical values of the organization are in place. And the tariff list is available to the patients whenever they ask. An updated tariff list, it should be updated once in a year. All these tariff lists, remember that they should be displayed in your letterhead with a time limit from this day to that day. And your signature stamp and is required as the owner of the hospital. So patient and family are, of course, again, expected cost, very, very important. Again and again, we realize that the estimated cost expenses of the procedure is something which is very, very important, and patients should understand that. The sixth standard says that there's a mechanism to capture patients' feedback and redressal of complaints. This is very, very important. You know, there is something like patient feedback and another is patient experience. Feedback is something which we say that, you know, when you go to a restaurant, you say average, good, excellent. That is a feedback. But that, of course, is a part of a mandatory patient feedback survey which you need. But I would sort of request all of you to look at patient experience, a one-on-one capture of patients' experience. They are the ones who are going to really help you improve your services. And that's the only way in which we can sort of see that our organization grows from strength to strength. PRE 6B says the ECO has a documented complaint redressal procedure. Of course, again, repetition of the same thing, but I would like to again emphasize that just taking a complaint is not enough. What have you done? How did you analyze? You know, what was the action taken on that complaint is very, very important. Organization has a system for effective communication is the PRE 7 with the patients and our families. And 7A says that there should be documented policies and procedures. How are you going to do the communication? And that's very, very important. Documentation of communication. Communication errors are the most common errors in medical science, and that is being proved beyond reasonable doubt. So that's the reason why this standard has been added in the full NABH standards. 7B says it defines what constitutes an unacceptable communication. So what is acceptable communication? What is unacceptable communication is something which should be defined, that cannot be done as a part of our organization values, policies, vision and mission. This is not allowed in this organization. And the staff is trained in healthcare communication periodically. Again, staff is trained, so training records should be in place. Thank you so much.